Existing in the middle of the lush and prosperous Sundanese area, which is rich of various culture, and natural magnificence. Becoming milestone in educating the nation, building persons to be society servants, and Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support education institution with various disciplines. By President Sukarno on 57. Today, UNPAD of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society. Nowadays, UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 150 Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, Postgraduate School. Realizing the importance of learning process, curriculum and learning method are continuously developed in order the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge, skills, attitude and behavior with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing graduates. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Padjadjaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities such as library, Basic Science Service Center, Language Center, e-learning, teaching hospital, and dental hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Padjadjaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Padjadjaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research implementation have been conducted to give real benefits for all society. Universitas Padjadjaran, straightening and developing together with society. From West Java, for Indonesia, to the world, through SDGs.
Greetings from Transcendent 2021, massive open online course in cleft, lip, and palate, held by Faculty of Dentistry, Universitas Padjadjaran, in collaboration with Smile Trend and Indonesia's Cleft Center, also granted by Ministry of Education, Cultural, Research, and Technology. So this course has been going on for a few weeks. Let me introduce myself. My name is Alia. I'm today Master of Ceremony, and I'm a student from Faculty of Dentistry, Universitas Padjadjaran. Since we come from different countries, so I think it is appropriate for me to say good morning, good afternoon, and good evening for everyone here. Greetings to Dr. Karoon Agrawal. So Dr. Karoon is a consultant in National Heart Institute, East of Kailas, India. Hello, Doctor.
Hello, good morning. Hello.
Good morning to Doctor. Thank you, Doctor, for being here. It's been an honor for us to have you here with us in today's live discussion sessions.
Thank you.
Yes, Doctor. Also, we have Syifa Byandra, Bachelor in Dentistry. She is one of a student at Faculty of Dentistry, Universitas Padjadjaran, as our moderator. Hello, Syifa.
Hello, good morning, Alia. Good morning, Doctor, and good morning, everyone here.
Okay. Also, I would like to greet all of the participants here. Thank you for the excitement for learning about cleft lip and palate, and thank you for attending today's live discussion sessions. So, Doctor, today is our third live discussion, and this is the 7th week. This week, we already learned about cleft speech therapy and multidisciplinary team approach to cleft care. In today's live discussion, we are going to discuss about assessment of velolaryngeal dysfunction with Dr. Karoon. So, Doctor, this live discussion will be separated into 2 sessions, which is the first session. Dr. Karoon will answer the questions that participants have been filled out in the MOOC website. The questions will be presented on the screen. After that, we will accept more questions from the participants here. Participants can ask the questions directly to the Dr. Karoon or through the chat section. Don't forget to write down the question, your name, and where you are coming from, the institution and country. So, Dr. Karoon, for your information, the participants have already watched your lecture in the website. I think not everyone can make it into this live discussion session, but I'm pretty sure that more than 600 participants from around the world that have been registered into our course have watched your lectures as well. This live discussion Zoom recording will also be available in MOOC website, so the participants can access this video every time and anytime. In the first session, I would like to give the spotlight to Syifa as our moderator and Dr. Karoon as our speaker. Please, Syifa and Doctor, time is yours.
Hello, everyone. So committee, please share the screen to see the questions that have been asked by the participants. So Dr. Karoon Agrawal, are you ready to answer the questions, Doc?
Sure, Syifa. It will be a pleasure. I am ready.
All right, doctor. So I saw that there are a lot of questions regarding this topic, and I think a lot of our participants are so interested in this phalopharyngeal disease. So I think we could continue to the first question. Next, please. So number one, the question is from Tasia, Universitas Pajajaran. The effect of phalopharyngeal dysfunction on resonance and articulation differ from child to child. What often happens is the effect of the case in India.
Yes, very relevant question for children with cleft palate and velopharyngeal dysfunction, that from different places the children will have different types of articulation, different languages, different resonance, as well as there will be a lot of difference in the pitch of the voice. Just like Syifa is having very soft voice and low resonance, and I am little loud and my voice is resonating more, and it has got low pitch, and girls will have higher pitch. All these differences will be there from person to person. So in India, it's quite relevant because different states and different parts of the country has got different languages, and articulation is quite different in different parts of the country, and there is lots of differences in their resonance, pitch, and the way they speak. So it becomes a challenging task for the Indian surgeon as well as Indian speech language pathologist. For a period of time, every language has got now a scoring system or assessment pattern for speech language pathologist, and they have got a different guidelines and different scoring systems. Just like Tamil has got a Tamil scoring system, Hindi has got Hindi scoring system, English scoring system. So all these things have been developed over a period of time to take care of difference in the articulation pattern of different children. And this helps in deciding that it is a difference in the basic articulation of the child or differences because of the cleft palate. So if there is a velopharyngeal dysfunction, that can be assessed by articulation test or articulation scoring by the speech language pathologist in that particular language. So that's how we have been able to circumvent the problem of difference in the articulation, resonance, and pitch in the children in normal way. So that is taken care by, to a large extent, by developing these tools of assessing speech in different languages. Clear?
Okay, doctor. So from your answer, the way assessment according the language, the dialect of the area, right, doctor?
Yes. One has to develop
Alright,
the
so
tool. One has to develop the tool for different language and different regions. The way they speak, one has to prepare the tool.
all right, so it's clear, doctor. Thank you for your answer. Next question. From Farah Shakira, Universitas Pajajaran, what is the largest distance of the velopharyngeal gap you have ever found? Does the distance affect the level of difficulty in repairing the gap?
The largest distance of VPS gap. Now, before that, before answering this, one should know that we can measure the distance of the velopharyngeal gap only by video fluoroscopy. With nasendoscopy or nasometer, we cannot measure the gap of the velopharyngeal sphincter. That is measured only by video fluoroscopy. So if somebody is doing video fluoroscopy, then only one should be able to measure the gap. Now, if we see the gap, the distance which I have seen is almost like 4 centimeter. And even if it is 4 centimeter gap is there between the palate and the pharynx, we should be able to provide some surgical support in the form of the sphincter pharyngoplasty or pharyngeal flap. Different techniques are there by which we can manage these patients. But these distance, the distance is less important. There are other factors which are important in management of the velopharyngeal dysfunction. Just like I said that when endoscopy is done, what type of closure is there? Is it concentric? It is horizontal or it's a vertical closure? Which element is functioning? Is it palate is moving or the posterior pharyngeal wall is moving? Lateral pharyngeal walls are moving. And while moving, is there any formation of the groove on the palate so that it indicates that muscle is not repaired well? So these are the many factors which are to be assessed when we decide about the management. So the distance is important, but it is not the sole parameter which decides about the management of velopharyngeal dysfunction. Thank you.
All right, doctor. So the answer is the distance could go to 4 centimeter in which a surgical intervention is feasible, but not only the distance that is important, but a lot of factors are also important. For example, what type of closure and which part is functioning, maybe the palate or etc. So distance is not the sole parameter of difficulty in repairing the gap, right, doctor?
Absolutely.
Okay.
Absolutely.
I hope it answered the question, Faras. On to the next question, please, committee. So from Gretanza, Universitas Pajajaran, besides cleft palate, VPD is also common in children with other genetic conditions. What are the conditions that you find most often, doc? Thank you.
As cleft surgeon, we normally see most often VPD following cleft palate surgery. Means 99% of my patients with VPD are following cleft palate repair. Now, there are very few children who come without cleft, but they have got VPD. One, I have got few patients who are Down syndrome who have got VPD. There are few patients who have got cerebrovascular palsy or cerebral palsy. They have got VPD. There is a third type of patient which came to me with VPD is paralysis of the palate. And one of the patient has got unequal paralysis. The right side had more paralysis and the left side had almost like normal functioning. So in that, the velopharyngeal sphincter will close unequally on two sides. So And there are other, you are talking about genetic conditions. Apart from genetic conditions, there are space occupying lesions. I have not seen space occupying lesion causing velopharyngeal dysfunction, but it can be a major factor causing velopharyngeal dysfunction. Few patients of large tonsils on both sides, they hamper the closure of the velopharyngeal sphincter. This is not genetic, it is infective, but this can cause. So how we classify is, one is the cleft, second is the space occupying lesions, third is neuromuscular reasons why it causes the velopharyngeal dysfunction, and fourth is phoneme specific. They have VPD in some language, some articulation, and it is not there in some other. And fifth is the mislearning. You do not have velopharyngeal dysfunction per se, but child has not learned well. It may be because of the hearing defect, or it may be because of the wrong training to the child. So these are the 5 reasons why one can have. But as far as genetic condition is concerned, it could be Down syndrome, it could be Appert's, it could be Cruzen's. So very few other syndromes are there which cause VPD in our children. Thank you.
Thank you, doctor. So I heard that there are 5 conditions, right, doctor? Genetics, in which there are Down syndrome, cerebral palsy, or paralysis of the palate. Is that correct?
Yes.
And then neuromuscular, and then mislearning because of hearing defect, and space occupying lesion. And can you repeat one more, because I think I missed the other one, the one point of 5. All right, cleft palate. Oh yeah. Oh, cleft palate is included in the 5. So cleft, genetics, neuromuscular, mislearning, and space occupying lesion. And you said that you haven't found a space occupying lesion case in which it causes VPD. But is there any journal or any article that, or any case report that has been reviewing about the space occupying lesion causing PPD?
In fact, angiosarcomas are very common otolaryngology problem which occurs in the nasal cavity and nasopharynx that causes VPD, because it blocks the nasal cavity and it can hurt the movement of the palate. So that's a common reason why it causes a common tumor which causes the VPD. But there are many articles which are there in the literature which are mentioning, but they are not truly directed towards VPD too much. There are very few articles which are really talking about space occupying lesions causing VPD. When there is some article in which there is a demography or the analysis of VPD, this figures as one of the causes of the VPD. There may not be isolated paper. I have not seen isolated paper on space occupying lesion causing VPD.
All right, doctor, thank you. And so there are one point that I think I'm curious about. You said that mislearning or hearing defect in children could affect VPD, could create VPD in children. So because she or he has hearing defect, how to treat that? I mean, the person, how to teach or how to make the children know that it's different. It's she has a dysfunction in the velopharyngeal, because if it's treated, she or he won't even notice it's being different. And I'm sure they are probably used to the how they pronounce things, right, doctor?
Yes.
So how do you handle in hearing defect patients?
This is very intricate situation and very difficult for the speech language pathologist to manage. But with lip movement and sign languages, speech language pathologist is able to train these patients how to speak better. I don't say that they are totally treated, but what happens, these children, because of the sign language and this support from SLPs, they develop confidence in speaking. Even if they are not able to listen fully, they are able to develop confidence and they keep talking. The moment they start talking and they start conversing, their language improves further. And now, because of many good hearing aids and you have got now implants and cochlear implants and many other procedures, technology development is there. So now these children are able to, large number of these children are able to listen in due course of time after surgery and with the support of the speech language pathologist. So many of these children, they ultimately land into good language. And most of these children do not require any surgical management. They require rehabilitation with speech language pathologists. They have to stay a little longer, but they do not require surgery, most of them. They require support of his SLPs. They don't require support of surgeon like me or you.
All right. Thank you, doctor, for the
Yes.
answer. That's nice to hear that there are a lot of interventions and there are a lot of things that you can do to help patients with VPD, whatever the causes are. So next question, please,
Yes.
committee. Maulida from Universitas Pajajaran. So in the lecture, it is said that in doing nasoendoscopy, we should note about the uvula. How does the condition of the uvula affect pharyngeal dysfunction?
Good. See, you can have bifid uvula or the two uvulae in two situations. One, before surgery itself, pre-operative. You have not operated the patient, and you can have bifid uvula. And second is you have operated, the operated patient post-operative, you can have bifid uvula. So what does it indicate? Pre-operatively, if you have got bifid uvula, this is one of the signs of subsurface cleft palate or submucosal cleft palate. So it has got triad of signs. One is bifid uvula, second is zona pellucida, and third is notch in the posterior border of the hard palate. So these three indicate submucosal cleft palate. So the mucosa has united, but the muscle in the soft palate has not united. So this is pre-operative. If you have got bifid uvula in patients who are already operated for cleft palate, so in these patients, you may just have bifid uvula, but there may be, the surgeon must have been good and he must have repaired the muscle sling well. So in these patients, you may not have very bad VPD. Velopharyngeal incompetence may not be there if muscle is repaired well and bifid uvula is present. But if subsurface cleft palate is there, muscle is not united, bifid uvula is there, and the patient is not speaking well. So these patients will require management of VPD. In both the conditions, one has to give good amount of speech therapy and then see if the speech becomes normal or it improves, then surgery may not be required further. If the speech therapy support, in spite of support for a few months, if the child continues to have normal speech, then we need to do diagnostic instrumentation and then manage it surgically. Thank you.
All right, so it is a complex, complex treatment, right, doctor, to detect the VPD and also the intervention. It is different from patients to patients according to the situation and the outcome of the operation. Okay, so doctor, maybe we can go to the next question.
Sure.
Next question, is there any more question, committee? So it is the last question from the presentation, from the forum. And I think I see a box. Could you move it to the committee so that we can read it?
What is the difference between adult patients and younger patients in terms of their attitude towards their patients?
Wait, Dr. Karoon, while the committee is moving the question to the presentation, there is someone that raised her hand. Okay, Mutiara, you can unmute and ask the question directly to Dr. Karoon.
Thank you, Syifa. Hello, doctor. My name is Mutiara from Universitas Pajajaran. I want to ask, what is the main factor that implicated in the occurrence of VPD? Is there anything we can do to reduce the chance of VPD in cleft patients? Maybe such as surgical technical usage, doctor? Thank you.
Syifa, can you repeat that?
All right.
Maybe I will
Mutiara
repeat the question. Right,
yeah,
Doc.
please.
Can you hear me clearly, Doc?
Sure. Now I am able to hear clearly. Yeah. Please go ahead.
I want to ask, what is the main factor that implicated in the occurrence of VPD? Is there anything we can do to reduce the chance of VPD in cleft patients, maybe such as surgical technical usage? Thank you, Doc.
Yeah, now I'm clear. So in cleft palate, the function of the palate depends on the muscle sling surgery in the soft palate. There are two ways you can reduce the chances of VPD in cleft palate surgery. One, you should operate cleft palate in such a way that it should not cause any fistula. It should be fistula-free closure. The moment you have got fistula, that means there is a scar, there is a defect, and the air will leak through fistula and it will cause scarring, which will reduce the mobility. So first thing is fistula-free good closure of the palate. Second, the muscle sling, the soft palate muscle, levator and palatopharyngeus. These two muscles should form very good sling in soft palate. So when you have got very good sling in soft palate, the mobility of the palate will be more, and it will have very strong mobility to close the velopharyngeal sphincter. And third, which is important in the functioning of the palate, is the length of the palate. So you should repair the palate in such a way that it should become as long as possible. So there are three ways you can reduce the possibility of velopharyngeal dysfunction or VPD or velopharyngeal incompetence in cleft palate patient. One, fistula-free closure. Second, you should reconstruct the palate as long as possible. And third is very good tight muscle sling repair or reconstruction of the palatopharyngeus and levator veli palatii. So these three methods will reduce the possibility of velopharyngeal dysfunction in our cleft palate surgery patients. Hope I am clear, Murtaza.
Okay, doctor. So there are three ways to reduce the chance of VPD in cleft patients. The first is operate the cleft that as best as not causing, because the defect can lead to fistula.
Yes.
The second is the length of the palate is we make it as long as possible. And
Yes.
the third is very good tight muscle sling repair. Is that correct, Doc?
Perfect. Perfect, Murtaza.
Okay. Thank you
Very
so
good.
much, doctor.
Welcome. Welcome, Murtaza.
Okay, so that's a really good question, yeah, Doc, from Mutiara. So we will move on to the question in the chat box from Sasti, Universitas Pajajaran. What's the difference between adult patients and younger patients in terms of their attitude towards the treatment in VPD patients?
This is a very good question, because when you have got adult patients, it is very difficult to change them. Whatever they have learned, they get, even if they have got bad speech, they get adjusted to their friends, their parents, and they don't want to change whatever they have achieved. Second, whatever you do, it requires a lot of effort from the patient to train, to do speech therapy, and to undergo a lot of training from SLP to change the voice when in adult patients. Younger patients, they are in habit of going to school and they keep learning continuously from their parents and teachers. So they don't mind going to a speech language pathologist, and they undergo very good training and they imbibe whatever the SLPs give directions and training to them. They are ready to play with toys, they are ready to play the balloons, they are ready to play the musical instruments, whichever is required for the improvement of management of VPD in younger patients and adult patients or the grown-up patients. That's why we say that VPD should be treated as early as possible, and we should take children with VPD around. They are in process of learning, they are in process of accepting the teachings, and they will modulate their voice whenever we are training them. Once the maturity is there, once the patient becomes adult, when they are mature enough and they are adjusted to their circumstances, very difficult to train them. And we can also prime them beforehand, the adult patients, that it is not possible to give you absolutely normal speech at the end of VPD treatment. It's very difficult to get back to normalcy once it is abnormal speech, because the learning is here, not here. So here, whatever is there, it is difficult to change. Here we can change with surgery or modulation, but here it is difficult to change. That's why it is very relevant that the person who is trying to treat VPD patients, they have to counsel adult patients beforehand. May be possible to reach to normalcy in spite of all our efforts at surgery and SLP's effort to train. While in children, it is possible to get much better result. Thank you, Syifa.
It's very different, right? The answer, because younger patients, they tend to be in a learning phase in which they can still adapt to whatever the speech therapists teach them in the future. But adult patients, we have to set certain expectations so they don't first, they don't have really high expectation in which they can speak normal again, and to control their motivation, right, doctor? Because if they don't see any advancement in their speech, maybe they get disappointed and they lose hope in the doctor, and they will just don't care anymore about the treatment. So in adult patients, it is important to have good communication, right, doctor, between the doctor and also the patient, and set a really in which the speech therapy and also the treatment outcome.
Yes, absolutely right.
Okay, doctor. Absolutely. So there is one more question. Oh, doctor, there are a lot of participants that are interested in this topic. Next question, please, committee. From Josefinda, Universitas Pajajaran. Based on advantages and disadvantages on every instrumentation, which techniques do you prefer? Is it naso-endo? Thank you, doctor.
Syifa and Josvinda, I use nasoendoscopy regularly for assessing the nasometry. And nasometry is basically used for seeing the follow-up results and doing some research activities, feedback to the patient. The nasometry is not very important. What is important is nasoendoscopy and video fluoroscopy. I do not use video fluoroscopy in my setup. I use mainly nasoendoscopy, and I prefer because it gives three-dimensional view, color picture. I can make patient speak well and palate, pharynx, and lateral pharyngeal walls. And also I can see the muscle activity. I can see if there is any fistula. I can see if there is any nasal deformity, space occupation, or evidence of any other scar or surgery there in the palate. So that's the advantage of nasal endoscopy. That's why I use, and I'm using nasal endoscopy for past 32 years, 33 years. And I have done more than 1,000 nasal endoscopy. So I'm very about this. I use rigid endoscopy for adult patients, and I use flexible endoscopy for children, wherever the children are cooperative enough. So I'm very happy with nasal endoscopy, and I will the cleft use nasal endoscopy and video fluoroscopy to assess the. That all depends on the infrastructure one has. If you have got video fluoroscopy imaging system, one can use, and it is not very difficult. Earlier it was difficult video fluoroscopy, but now C-arm is there in most of the hospitals. Cardiac cath lab is there in most of the hospitals. So all these apps can be used for video fluoroscopy. So, but I use the nasal endoscopy as my choice.
All right, so doctor, from the question, nasometry is not really an important instrument in follow-up result for research activity and also for feedbacks to the patient. And from your years of expertise, you use nasoendoscopy because it could detect muscle activity, dilation, and evidence of scar, and also fistula in the from the nasoendoscopy. And also there is video fluoroscopy, right, doctor? And you could also use that if it is available in your cleft center. But nasoendoscopy is enough for Dr. Karoon as his 30 years of experience, right, doctor?
Yes.
So
thank you.
I think that is the last question from this session, doctor.
Okay. Good.
Is there anything that you want to tell us about this VPD, or maybe closing remarks? Because this is your last live discussion, right, doctor, in this series of cleft lip and palate course?
Yes, this is my second and last lecture in your very good, very well organized cleft lip and palate master classes. And what I can say about this particular topic is, this is a little difficult topic. VPD management or VPI management is a little difficult topic for cleft specialists or cleft surgeons. But once you start taking, not very difficult to learn. Most of surgeons, maxillofacial surgeons and plastic surgeons, we are quite reluctant to use equipments like endoscope. While you see the ENT surgeon and and other surgeons, they use endoscope very commonly. So it is not difficult to learn. If other surgeons can learn, we can also learn. So endoscopy is not very difficult. Second, we are very happy to operate cleft lip and palate surgery when the children are coming. But when they have got speech abnormality, we send the patients somewhere else. But now it's high time that we must develop VPD center in our own cleft centers, and it requires availability of nasoendoscope and availability of speech language pathologist. These, you can assess the VPD very well, and based on your assessment, you can manage these children, and many of the children do not require surgery. After assessment, you can manage these children with the help of speech language pathologists. If they give good therapy, children improve and they do not require surgery. But if they are not improving, they will require surgery. And surgery is also not very commonly done, but it is not very difficult. You can do close, you can do palatoplasty, you can do surgery, you can do the interpharyngoplasty. So these which we are doing for VPD. But my topic is the assessment. Assessment is not very difficult. And one has to get into the learning. We are learning so many surgeries. We are learning so many equipment. Are using the maxillary distraction devices. They are more difficult than endoscopy. So I think we must inculcate the idea of learning and idea of practicing VPD assessment and VPD surgery. Our all students and consultants who are managing the cleft patients and any patient other than cleft patients also, we should assess the VPD and then operate. And I can also say that one should not operate these VPD patients unless you have seen inside the velopharyngeal sphincter. Because I have seen many surgeons, once the speech is abnormal, they will go ahead and do some surgery which they want to do for all the VPD. It is not correct. You should always assess and then operate. Your result will be much better.
Thank you, Doctor, for the remarks. It was a great session. Now move on to Alia as the Master of Ceremony to close this session. Thank you so much, Doctor. Thank you so much, Alia.
Thank you.
I think that was the of our live discussion session. It was a great opportunity for all of us here, hearing the valuable knowledge from Dr. Karoon Agrawal on this special occasion. And also thank you for Syifa for moderating the session. In these hard times of pandemic, we still can find the bright side, which is this course. This course. Everyone in the future will be specialized in oromaxillofacial surgeon. I believe that this course will be an inspiration for all of us here to learn more and more cleft lip and palate. Even further, to implement as the best treatment that we can serve to the cleft patients. Join discussion session. The committee by you upcoming live discussion session, email and WhatsApp group. Before we end today's session, maybe we can take a picture for all the participants around the camera. Okay.